Okay, so now we will discuss GIT physiology, pathology, and pharmacology. Okay, so these are important high yield points that you should know. First of all, regulatory substances. So, gastrin is secreted by G cell in the antrum of stomach duodenum at and it increases gastric acid secretion and growth of gastric mucosa. Okay, so it increase acidity in the stomach and increase the growth of gastric mucosa. So if there is a lot of gastrin producing tumor which is known as gastrinoma, okay, so the person will be having hypertrophied gastric mucosa and there will be increased H plus secretion. Now, gastrin is stimulated by stomach distension, alkalinization, amino acid peptides, and vagal stimulation, a gastrin related peptide. Okay, so whenever there is stomach distension, food come in the stomach, so it distended. So it is a stimulus for the secretion of gastrin. And if there is amino acid protein, so acid is required for its breakdown, so gastrin is releases and in turn it's secreted acid. Okay, so gastrin secretion is inhibited by a pH of less than 1.5. So if the environment is really acidic, then gastrin secretion is inhibited. Now, gastrin level are greatly increased in Zollinger-Ellison syndrome, gastrinoma. Okay, gastrinoma is a gastrin secreting tumor in which there is increased gastrin and gastric mucosal hypertrophy and increased acidity in the stomach. So this is Zollinger-Ellison syndrome, and this syndrome or this tumor can be found in pancreas. Then there is another substance which is known as ghrelin. So ghrelin is secreted by the stomach and it increases appetite. Okay, so it increases appetite. Now ghrelin level are increased in fasting state and decrease after food or gastric bypass surgery. So whenever a person is uh, taking something or have take something, so there is decrease amount of ghrelin, but whenever he is in fasting, so their ghrelin is increased in amount. Then somatostatin is secreted by D cells and inhibit the secretion of various hormone, encourage somatostasis. Okay, now octreotide. So octreotide is somatostatin analog and it is used to treat conditions like carcinoid syndrome. Or carcinoid syndrome is a condition in which there is a tumor and it secrete serotonin or something that is hormone related or substance related. So this is secreted. So octreotide is used to treat that condition, and also variceal bleed. Okay, so for esophageal varices we use octreotide, terlipressin and octreotide, and for its prevention we use beta blocker. Now cholecystokinin. So cholecystokinin is secreted by eye cell in the duodenum and jejunum, and it's stimulated by fatty acid and amino acids. Okay, now cholecystokinin increases pancreatic secretion and gallbladder contraction and causes relaxation of sphincter of Oddi. Okay, now this is pancreas and then it is joining the common bile duct and then it secretion goes into the duodenum. Here is the sphincter of Oddi. Okay, so these secretion are also stimulated and this sphincter of Oddi is relaxed. So then the secretion can easily go into the duodenum. Okay. Now, secretin is secreted by S cell in the duodenum and is stimulated by acid and fatty acid in the duodenum lumen. What is the function of secretin? So secretin enhance bicarbonate secretion. Okay, bicarbonate secretion into the duodenum to alkalinize the gastric acid. Secretin main function is to increase pancreatic bicarbonate secretion to neutralize gastric acid. Now, glucose dependent insulinotropic peptide GIP. So this is secreted from K cell and it increase insulin release endocrine, and exocrine function is decrease gastric H plus secretion. Okay, so GIP increase insulin release while decrease acid secretion. Now, GIP secretion cause the insulin response to oral glucose to be greater than an intravenous equivalent. Okay, now if a person take glucose by mouth, okay, so it will not increase the plasma glucose concentration as much as in the person in which we give IV glucose, okay, because oral glucose there is GIP secretion and GIP secretion will increase the insulin. As a result, insulin will shift the glucose inside the cell. Now, motilin. So, motilin is secreted by small intestine and produce migrating motor complexes, MMCs, in fasting states. Now, VIP, vasoactive intestinal peptide. So, this increases intestinal water and electrolyte secretion and relaxes intestinal smooth muscle. Okay, so VIP increases water and electrolyte secretion in the intestine and it relaxes the intestinal smooth muscle. Now, what is Vipoma? So it is the tumor of VIP secreting cells. Okay, Vipoma is associated with WHA syndrome, WDHA syndrome, watery diarrhea, hypokalemia, achlorhydria. Okay, because why there will be watery diarrhea? Because this VIP vasoactive intestinal peptide, this increase the secretion of water and electrolyte, and as a result there will be diarrhea and achlorhydria. Okay, now nitric oxide. So nitric oxide causes smooth muscle relaxation and its loss is implicated in increased lower esophageal sphincter tone of achalasia. Okay, so nitric oxide, it is mean used to relax the smooth muscle. Okay, and what happened in achalasia? So in achalasia, there is increased tone of the esophageal sphincter. Okay, so there is loss of nitric oxide. Okay, function. So we can give some alternatives for the relaxation of this esophageal sphincter, like calcium channel blocker, and we can give that's myotomy, all these. Okay, now secretory product and digestion. So parietal cells secrete gastric acid and intrinsic factor. We have already discussed this in anatomy. Now gastric acid secretion is increased by histamine, vagal stimulation, and gastrin. Okay, now this is the gastric acid. Okay, so it is increased by gastrin, it is increased by acetylcholine or vagal stimulation, and also increased by histamine. Okay, So these are the substances that increase the gastric acid secretion. Now, intrinsic factor is necessary for vitamin B12 uptake in the terminal ileum. Okay. Now, vitamin B12 is absorbed in the terminal ileum. Okay. You have to make fit this in mind that vitamin B12 is absorbed in the terminal ileum, but in the stomach, this intrinsic factor is bounded to vitamin B12 and then it is carried towards the ileum and then in the ileum it is absorbed. Okay. Now, if there is intrinsic factor deficiency, so there is vitamin B12 deficiency. Now, cheap cells, so these are basophilic, while the parietal cell are eosinophilic. It secrete inactive pepsinogen. Okay, then it is converted to active pepsin by acid. Okay, and then this pepsin work on the protein breakdown and all these. Now, bicarbonate, so it is secreted by Brunel gland in the duodenum and is trapped in the mucus covering the gastric epithelium. Now, gastrin primarily increase acid secretion by acting on ECL cell to cause histamine release. Okay, this is ECL cells and its function is to secrete histamine, and histamine will cause the parietal cell to secrete H plus. Okay, so this gastrin act on this ECL cell and it secretes histamine. In turn, it increases the H plus secretion. Now, pancreatic fluid, so it is isotonic. Pancreatic fluid is isotonic. At low flow rates, pancreatic fluid is high in chloride. At high flow rate, it is high in bicarbonate. So now when pancreas is secreting the exocrine fluid, as we know that pancreas is exocrine and endocrine, both, it's having both functions. So on the exocrine point of view, whenever its secretion is in greater quantity in speed, so it secrete bicarbonate, its secretion will be high in bicarbonate. But when there is low flow rate, so then there will be high in chloride. Now, pancreatic proteases are secreted as inactive proenzyme, that is zymogen. Then trypsinogen is converted to active trypsin by enterokinase or enteropeptidase, a brush border enzyme. Okay, it is present in the lumen. Now, trypsin then activate other proenzyme in a positive feedback loop. Okay, so this is trypsinogen. Trypsinogen is activated, then it activates series of enzymes, and these work in protein digestion. So now absorption. On the monosaccharides, glucose, galactose, fructose are absorbed by the enterocytes. Glucose and galactose are absorbed by SGLT1, sodium dependent on the apical membrane, sodium glucose transporter, okay, SGLT1. Now, fructose is absorbed by GLUT5 via facilitated diffusion. Now, all monosaccharides are transported out of the cell into the blood by GLUT2 on the basolateral membrane. So, all the monosaccharide are transported out of the cell into the blood by GLUT2. Now, the D-xylose test detect proximal small intestine mucosal damage. Levels are low but is normal in pancreatic insufficiency. Okay, whenever there is pancreatic insufficiency, so the D-xylose level will be normal. So, what we actually do in this test, D-xylose is the common sugar, okay, simple sugar. So it is absorbed by the GIT lining. Okay, just intact GIT lining is required for its absorption. So if there is damage to the GIT mucosa, so then its level will be low in the body. But if there is pancreatic insufficiency, okay, so pancreas is not required for its absorption. So then we can conclude that the D-xylose level in the body, whatever we have given the patient, it is all absorbed into the body and its level is normal. So this is pancreatic insufficiency. And we usually this D-xylose test in those who are having trouble in the absorption, who are susceptible, that we think that these people are maybe having malabsorption. Okay, so this test is used to find out the cause of malabsorption. If the D-xylose level in the body is normal, then we conclude that this is pancreatic insufficiency, and if the D-xylose level in the body is low, then we conclude that there is mucosal damage. Okay, then iron is absorbed as Fe plus 2 primarily in the duodenum. Okay, so we can remember it as 2 into the duodenum. Okay, 2 into the duodenum. Okay, 3 plus is not usually absorbed. Fe3 plus, first it will be converted into Fe2 plus and then it will be absorbed in the duodenum. Now folate is absorbed throughout the small intestine. So folate is absorbed throughout the small intestine. Vitamin B12 and bile salt are absorbed in the terminal ileum. And deficiency in B12 and fat soluble vitamin in the can occur after terminal ileum resection. Okay, so those who have resected ileum due to some reasons, so they are at risk of getting vitamin B12 and fat soluble vitamin deficiency. So now iron is absorbed in the duodenum and Fe2 plus is formed. Then folate is absorbed throughout the small intestine. Then vitamin B12 and fat soluble vitamin is absorbed in the terminal ileum. Okay, now pathology. Okay, so esophagus, stomach, and small intestine. So what is GERD? Okay, so GERD is gastroenteric reflux, gastroesophageal reflux disease. It is associated with decreased lower esophageal sphincter tone. Okay, this is the esophagus, and then it open into the stomach. Okay, there is a sphincter. If the sphincter is relaxed, okay, so then the gastric content will reflux into the esophagus and it will destroy the esophageal mucosa. Okay, as a result, the esophagus will change its epithelium. Normally its epithelium is squamous epithelium, okay, stratified squamous epithelium. But to cope with this acidity, it will convert its epithelium into simple columnar epithelium with goblet cells. Okay, simple columnar epithelium with goblet cells, and this is metaplasia. And this condition is known as Barrett's esophagus. Okay, so Barrett esophagus, intestinal metaplasia, squamous to columnar with goblet cell, is a complication of chronic GERD. Now, Barrett esophagus increase the risk for esophageal adenocarcinoma. Okay, Barrett esophageal is a prelude to esophageal adenocarcinoma. Now, esophageal adenocarcinoma is the most common type in the US, occur in the lower one third. Okay, now this is the upper 2/3, and now this is the lower 1/3. Okay, so upper 2/3, this is associated with squamous cell carcinoma. Okay, this lower 2/3, this is associated with adenocarcinoma. Now, those who are smokers and having uh, tobacco or alcohol use. So these are at risk for squamous cell carcinoma. And those who are at GERD, so these are associated with adenocarcinoma. Okay. So esophageal squamous carcinoma is linked to alcohol, tobacco, and occur in the upper two-third. Now, achalasia is caused by loss of Auerbach plexus, inhibitory neuron leading to increased LES, lower esophageal sphincter tone. Okay, so what happens? There are inside the esophagus, there are Auerbach plexus. Okay, these are the plexuslets. Okay, and this is the sphincter. Okay, what's its function? So Auerbach plexus, these relax the esophageal sphincter. If you lose this Auerbach plexus, what will happen? Esophagus will contracted. Okay, as a result, there will be no entry of food into the stomach due to tight sphincter. Okay, and on the appearance, we do barium swallow. Okay, we give barium to the patient, and on the barium swallow there will be bird beak appearance. Okay, there will be bird beak appearance on the radiology. Okay, now achalasia present with dysphagia to both solid and liquid, and a characteristic bird beak on barium swallow. Now, pill-induced esophagitis is often caused by bisphosphonate and tetracycline. These are irritants, so these are causing pill-induced esophagitis. Okay. Now, Plummer-Vinson syndrome. So, in the Plummer-Vinson syndrome, there is triad. Okay, what is the triad? There will be iron deficiency anemia, there will be glossitis, red BP tongue, and there will be esophageal webs. Okay, that will presenting to you as dysphagia. Okay, so Plummer-Vinson syndrome is the triad of dysphagia, esophageal web, iron deficiency anemia, and atrophic glossitis. Now, peptic ulcer disease. So, peptic ulcer disease is mainly caused by H. pylori and NSAIDs. Okay, so most common cause of peptic ulcer disease is H. pylori. This is the notorious bacteria, and NSAIDs. Now, gastric ulcer cause pain that increase with meal, leading to weight loss. So, if a person is presenting to you with ulcer, okay, you are suspecting that this is ulcer. So, if it is aggravated by food, so then this is gastric ulcer, because gastric acid secretion occur in response to food. So it will be aggravated by food. Now, if it is relieved by food, because when the chyme goes to duodenum, so it secretes bicarbonate and all these to neutralize the acidity, then this is the duodenum ulcer. Most common cause of the ulcer is duodenum ulcer. Okay. Now, duodenum ulcer causes pain that is relieved by meal, and it is leading to weight gain. This leads to weight loss. Now, Zollinger-Ellison syndrome. So, it is a gastrinoma causing high gastrin level and refractory peptic ulcer disease. Okay, so Zollinger-Ellison syndrome is gastrin secreting tumor, and the person will be having high gastrin level, and there will be refractory peptic ulcer disease. Now, Menetrier disease. So it is characterized by joint rugal fold due to mucosal hypertrophy and causes hypoproteinemia. Okay. So why hypoproteinemia is caused in this disease? There is achlorhydria in menetrier disease, okay, decreased gastric acid secretion. So if there is decreased gastric acid secretion, there will be mucosal hypertrophy and protein will not be absorbed, and this will lead to hypoproteinemia. Now there are two types of gastric carcinoma. Okay, one is the intestinal type and the other one is diffuse type. So the diffuse type of gastric carcinoma is characterized by signet ring cells and is not associated with H. pylori. And gastric carcinoma can metastasize to Wernicke node. Okay, these are supraclavicular node. Okay, and the Krukenberg tumor ovaries. Okay, so these can metastasize to Wernicke node and Krukenberg tumor. Now, celiac disease. So, celiac disease is autoimmune reaction to gliadin. Okay, that damage the proximal small intestine. It is autoimmune disease and its histology will show flattening of villi, crypt hyperplasia, and increase intraepithelial lymphocytes. Okay, so celiac disease is autoimmune and there will be flattening of villi, crypt hyperplasia, and it is reaction to autoimmune reaction to gliadin. Now, Whipple disease. So, Whipple disease is caused by a bacterium, Tropirema whippleyi, and it presents with diarrhea and periodic acid ship positive macrophages. Okay, in the lamina propria. Lactose intolerance. So this celiac disease and Whipple disease, these are invasive gastric disease. Lactose intolerance, it is due to lactase deficiency and result in positive hydrogen breath test. Okay, so we do hydrogen breath test. If it is positive, then we suspect that this is lactose intolerance. Okay, so how we do hydrogen breath test? We give a person sugar, carbohydrate, okay, and carbohydrate is normally absorbed from the body, but the person who is having uh, in absorption or problem in the absorption, so then it goes to the colon, and here it is converted into CH4 and hydrogen. Okay, so this hydrogen is just and then absorbed into the lung and then into the blood, and then it carries toward the lung, and from the lung it is excreted outside. So we if the hydrogen is present in the breath, so we conclude that there is lactase deficiency. Okay, now irritable bowel syndrome. So irritable bowel syndrome, it is a functional disorder and it is chronic abdominal pain. It is relieved by defecation. Now inflammatory bowel disease. So inflammatory bowel disease include Crohn disease and ulcerative colitis, and these are really important. Okay, in inflammatory bowel disease, Crohn disease, it affect any part of the GIT, while ulcerative colitis, it is limited to colon and rectum. Okay, and inflammation here is transmural. Okay, transmural mean it involve all the layer, mucosa, submucosa, muscularis, and uh, that adventitia, and then Crohn disease is characterized by skip lesion. Okay, this side, this is involved, then this is skipped, then this region will be involved. So there is skip lesion and there are granuloma, which is non-caseating in nature. Now in ulcerative colitis, there is it is limited to colon and rectum and cause mucosal and submucosal inflammation. Okay. Now, ulcerative colitis is characterized by continuous lesion. Okay, there are continuous lesion from rectum. It is started and then it involved the colon. Okay, extended proximally from the rectum and crypt abscesses. Now, toxic megacolon, so it is the severe complication of ulcerative colitis and Clostridium difficile infection, okay, which is caused by the antibiotic in which the Clostridium difficile invade the normal GI mucosa. Adenomatous polyps carry highest risk of malignant transformation. Okay, so there are polyps that may be benign, but adenomatous polyps that carry highest risk of malignant transformation. Now, adenoma to carcinoma sequence, so it involved mutation in APC to KRAS and then P53 in DCC. Now, FAP, familial adenomatous polyposis, this is autosomal dominant disorder. Okay, you should have to memorize it. Familial adenomatous polyposis, this is autosomal dominant disorder and it is caused by APC gene mutation. And if a person is having familial adenomatous polyposis, so there is 100% risk of colon cancer. So you will have to do prophylactic colectomy. Okay. Now, Lynch syndrome. So Lynch syndrome is a defect. Okay, this is defective DNA mismatch repair gene. Okay, it is caused by defective mismatch repair gene. Okay, in Lynch syndrome, there is colorectal cancer risk and there is endometrial or uterine cancer risk. Okay, there are also other related risks, but these are the two most important. Now, liver, gallbladder, and pancreas. So, hepatocellular carcinoma is highly associated with hepatitis B and C and cirrhosis. Okay, now HCC is often associated with high serum alpha fetoprotein level. Now, cirrhosis involves diffuse bridging fibrosis. Okay, so there is fibrosis of the liver via stellate cells and regenerative nodules. Now, portal hypertension. So, in the cirrhotic patients, they will get portal hypertension, and portal hypertension will lead to new collateral circulation, causing varices, esophageal varices, gastric varices, rectal varices. Okay, and ascites is pathological fluid in the peritoneal cavity. Okay, the one with distended abdomen due to increased hepatic sinusoidal pressure. Now, if a person is presenting to you with ascites fluid in the abdomen, so how will we identify that what is the cause of this ascites? So we used SAG ratio. Okay, serum ascites albumin gradient. Okay, if it is 1.1 or higher, so then it indicate that this ascites is due to portal hypertension. Okay, we measure the albumin gradients of the serum and then we measure the albumin concentration of the ascites fluid, acidic fluid. Okay, then we find a ratio, and if this ratio is greater than 1.1 or 1.1, then this indicates that there is a problem in the portal hypertension. Okay, if it is less, then there are other causes. Now, Budd-Chiari syndrome. So, Budd-Chiari syndrome is a hepatic venous outflow tract obstruction due to thrombosis. Okay, it is also seen in polycythemia vera. Cholesterol gallstone, so it is most common gallstone and these are typically radiolucent and are associated with obesity, estrogen therapy and Crohn disease. Okay, so we have a mnemonic for for the gallstone, which is fatty, 40, female, fertile. Okay, now pigmented gallstones, so these are associated with chronic hemolysis. Okay, why pigments? This is bilirubin stones. Okay, these are black stones and these are associated with chronic hemolysis and biliary infections. Brown stone and black stones. Now, risk factor for gallstones are often summarized by 8 F's. Okay, so female, fatty, fertile, 40, fair, feeds, fasting, and fibrates. These are fibrates are medication. Now, biliary colic, so it is triggered by gallbladder contraction. Okay, after fatty meal, and this forcing a stone into the cystic duct. And cholecystitis, it is the inflammation of the gallbladder, often from cystic duct stone infection, causing a positive Murphy sign. What is Murphy sign? When you ask a person to breathe and you will palpate deeply through the hypochondrium, okay, right hypochondrium. And when you palpate, when you palpate deeply and you ask the person to breathe deeply, so he will stop breathing. Okay, he will stop inspiration because the gallbladder is tender. So this is called positive Murphy sign. Now, acute cholangitis. So acute cholangitis is a biliary tree infection and it is presenting to you with Charcot-Triad, fever pain jaundice. Okay, you will have to memorize it like fever pain jaundice. Okay, Charcot-Triad is fever pain jaundice, fever pain jaundice. Okay, now there is another Raynaud pentade. This is the more severe inflammation, and there is Charcot-Triad plus altered mental status and shock hypotension. So fever pain jaundice, altered mental status are confusion and hypotension. Okay, now porcelain gallbladder. So porcelain gallbladder, it is calcified and it is having increased risk of gallbladder adenocarcinoma, and you will have to do prophylactic cholecystectomy. Now, acute pancreatitis, so it is autodigestion of the pancreas by its own enzyme. And there are a lot of causes of acute pancreatitis. And its mnemonic is I get smashed. Okay, so I stands for idiopathic, G stands for gallstone, E stands for ethanol, T stands for trauma, then S stands for scorpion bite, M stands for mumps. Okay, then A stands for autoimmune, then this S stands for steroids, and then D stands for drugs. So all these are the causes of acute pancreatitis. Okay, now diagnosis of acute pancreatitis requires serum lipase. It is more specific than amylase. Okay, our amylase 3 times or more of the upper normal limit. Okay, so we are having, let's 64 to 100 a normal level. Okay, so to diagnose pancreatitis we will have to above 300. Okay, now pancreatic pseudocyst. So pancreatic pseudocyst, it is a complication of the pancreatitis, and that is lined by granulation tissue, not epithelium. Okay, that's why it is called pseudocyst. It is not lined by epithelium. Okay, now gastrointestinal pharmacology. Okay, so